My name is Professor Jesús San Miguel. I'm working at the University of Navarra, and it is a pleasure to be with you today. During this IHA meeting, I am going to present on the management of high-risk multiple myeloma as part of the educational program. As you know, this is really a challenge because although we have made a major improvement in the management, particularly in the treatment and the follow-up of myeloma patients, those that have high-risk cytogenetics, extramedullary disease, high tumor burden, circulating plasma cells, all these patients usually do poorly. And therefore, we need to improve in the management of these patients. During this meeting, during this session, I have discussed actions to improve the outcome in the transplant setting, in the non-transplant setting, the elderly, newly diagnosed, as well as in the relapsed patient. And I can share with you good news because novel drugs has improved the outcome of high-risk cytogenetic patients. However, they are not able to overcome the negative impact of high-risk features. In other words, if you compare the outcome of high-risk patients treated with novel drugs, let's say proteasome inhibitor plus IMiDs, very important this combination, plus a monoclonal antibody, is better than a simple doublet. But in spite of this, the high-risk patients continue to have shorter survival than the standard risk if they receive the same treatment approach. Second, I think it's important to consider in this setting that the risk definition should change, because patients that do not achieve MRD negativity should now be considered also as high-risk patients. In other words, and this is particularly true if you have poor cytogenetics. In this context of the poor cytogenetics, if with whatever treatment you use, still there are residual tumor clonal cells with such a risk cytogenetic marker signature, the patient will relapse very early on. Therefore, we need to eradicate all the tumor cells, particularly in the high risk, also in the standard risk, but this is particularly true for the high-risk patient. Therefore, one of my messages is that we need to adapt in the high-risk, in the management of high-risk multiple myeloma patients, the treatment to this goal, to eradicate the tumor clone. And hopefully, new strategies harnessing the immune system, and we need to move up front or at first relapse, the bispecific antibodies, the cell engagers, the CAR-Ts, all the active drugs should be moved to the early phase of the management of the patients. And on top of this, early intervention, early rescue intervention should be implemented. In other words, let me say, if you have a patient that is having only a partial response, you need to change treatment. If you have a patient that has achieved a complete response, but still there is residual disease, you need to change treatment. If you have a patient that was MRD negative, but start to become positive, you need an early rescue intervention. This is the goal, to use the new strategies, harnessing the immune system, and early rescue intervention. And I think these are the main messages from my first presentation. Now, let me move to my second presentation that is going to discuss the efficacy and the safety of a BCMA target CAR T-cell therapy, ide-cel BB2121, in relapsed refractory myeloma patients. A total of 128 patients have been included in these studies, the largest study so far performed with CAR T-cells in multiple myeloma patients. They received 3 different dose levels, 150, 300, and 450 million CAR T-cells. Patients were heavily pretreated, median of 6 lines of therapy, 84% were triple refractory, 26% penta-refractory. Most of the patients required bridging therapy. Almost 40% had extramedullary disease. More than 1/3 were high-risk patients by cytogenetics. In spite of this panorama, I think we can look with really a positive view the results, because the overall response rate, including the 3 doses of CAR-Ts, was 73%, with 1/3 of the patients achieving a complete response. And this response rate increased to 82% and almost 40% complete responses at the dose of 450 CAR T cells, 450 million. And also the progression-free survival for the whole series was 8.8 months, duration of response 10.7 months, but at the maximum dose that we have tested, 450, the median PFS was 1 year, 12.1 months, and in patients achieving a complete response, it was over 20 months. Median overall survival, 19 months, but 78% of patients treated with ide-cel are event-free at 12 months. Regarding safety, treatment was well tolerated. CRS was the most common side effect, but this cytokine release syndrome, grade 3, was observed in less than 6% of the patients, even at the highest dose. And also, neurotoxicity was infrequent, with less than 6% of patients reported neurotoxicity. The most common side effects are neutropenia and thrombocytopenia, and only 5 deaths had been reported in the early phase of the treatment attributed to the drug, in 3 cases due to adverse events. 2 other cases were following myeloma progression, and the 3 cases with adverse events were 1 CRS, the other was Aspergillus pneumonia, and the 3rd one was gastrointestinal hemorrhage. Therefore, I think we can congratulate doctors, patients, and families, because we have now a new treatment approach for patients that otherwise will have no treatment options. And I would like just to thank all of you for sharing with me this data.